What causes eating disorders? Do we know? What's that?
Is that rhetorical?
Well, I had to take a drink, but yes, it's sort of rhetorical. But when a parent comes into your office or calls up to student health or whatever it is, and they say, well, how did that happen? What caused my child's illness? They better have some time, because you're going to have to go through a pretty long explanation as to how the field thinks about eating. We don't have one thing to say. We do have what we think of as a working hypothesis about what causes eating disorders. Has anybody heard the phrase genetics loads the gun, environment pulls the trigger? How many? Everybody? Good. So that's our working hypothesis. It's a good hypothesis. I think we can use that pretty well. It's the best thinking. It makes sense. We have twin studies. We have other studies that show us that genetics is clearly involved. But all of us who are in clinical practice, really, you cannot distance yourself or ignore the environmental factors. But sometimes you get a patient and you think, geez, I don't see any environmental factors, And sometimes you get a patient and you say, this is all environment. So we don't know how to parse that out. But here's the point. If it takes both things, and you have unprecedented anxiety and concern about food and weight in the environment, well, what's going to happen? Every person that has a predisposition is pretty much going to get triggered, because we're bathing in this stuff. We're immersed in this stuff, and in particular, it's one of the things I think is why you're seeing eating disorders show up at younger and younger ages, is because our kids are immersed in this stuff. And I'll come to social media in a minute, but this is a big factor. And we really have to begin to take this, and not that we don't take it into account, but to really understand it in that big way. Level of care is a construct of the managed care industry, right? It comes from insurance. It dates back to about the 1990s. Prior to that time, there was no need for level of care determination, because if you look on the left, there weren't any levels of care. All we had was inpatient and outpatient. And so there wasn't much that you had to do. If you absolutely had to go to the hospital, you went to the hospital, and once your days ran out in the hospital, you went home. And that's how level of care was determined. A level of care is essentially the implementation of medical necessity guidelines. Let me stop for a moment. How many folks here are working in school settings? And okay, good. Okay, thank you. So this is if you could start to look, there's a handout on your table, and you should start to read through that a little bit, because this is Walden's level of care, but all the insurance companies, all the managed care companies have the same thing, except it's on a computer screen, and the person has a headset, and they may or may not know anything about eating disorders. You can't be certain. Kim's laughing. She does this all the time. So this is how they have a grid like this, and it says what symptomatology you have to have to be able to get to particularly a higher level of care. What sounds simple, it's in writing. This is what it is, right? But it's not. Because each company has its own set of rules. Sometimes they'll tell you what they are, and sometimes they don't. I actually search for them, and many of them are published at this point. But the rules certainly don't cover all presentations or symptoms or configurations. They couldn't, right? The reviewers, just as I was saying, are often not experienced in the treatment of eating disorder, and that's probably the biggest problem. Another big problem is something we create. You have programs with similar names, but they actually don't have the same capabilities. Some may have one thing and some may have another. Some may have a doctor on campus. Some may have a doctor that comes once a week. Some may have nursing 24 hours a day. Some may have a nurse who comes in the morning for an hour. And they're called the same thing. So you don't really know. Savvy providers know how to sell their story. So I'm sure, we got a bunch of savvy providers in this room. Bob Bordonaro could sell anything to anybody, I'm telling you, and this is something that he's great at. But many providers become adept at figuring out what they want for their patient and how to get it, right? And then once you get through all that, patients have a mind of their own. Oh yeah. They may not even want to go to what you think is the right level of care, and they often don't. So this is kind of the algorithm that we think we're working through in a scientific way. A level of care is kind of a game, and it has potentially very serious consequences. That's the problem with it. That insurance companies often use it as a way to make decisions, but some insurance companies are very financially motivated, and so it's a way to deny care, to limit cost, to limit length of stay. Providers to justify admission to the level of care that either they have or that they want for their patient. And patients to gain reimbursement for something that maybe they're not really ready for, or that they, at times with patients, it's more around they should be at a high. We've had this discussion many times with insurers. Insurers say, well, they really need to be in the hospital, but they won't go. And then, well, they won't go. So, what? Why should I pay for partial when we know it's not going to work? We get that sometimes. So anyway, level of care should be about three things. Medical stability. That's number one. And that has to do with the actual physical condition of the individual. Kim went through excellent overview of this, what their condition is. Do they need medical monitoring? Do they need to be watched 24 hours a day? And that then becomes part of the second issue, which is behavioral control. Do they have behavioral control? Can they control their main symptoms long enough for the treatment to get started? What are those symptoms? Binging, purging. And the one that we see a lot, frankly, is overexercise, is just constant movement. That's very hard to deal with. And finally, motivation. What will the patient actually do? So these are the three big things that you have to look for. It requires an extensive evaluation. And then the kicker to it all is comorbid conditions, is the understanding and the existence of comorbid conditions. And oftentimes, the only way to get even somebody with serious anorexia who seems to be medically stable, which is really, makes no sense for many of the ones that I'm talking about. But the only way to get them for reimbursement for inpatient is to talk about their suicidality. All right, so if you look at the handout a little bit, first of all, I have to say that again, it looks more organized on paper than it actually is in practice. Exceptions are the rule. All right, so we really look at each patient individually, but it's good to have a place to start with. And what is most important for you all to look at is just how, if you look at the different columns, you have the level of care, you have what the focus is, and then you have, what actually takes place there, what are the features, and then some medical issues. Like not recommended for, somebody, with a heart rate of, so inpatient for us, as a psychiatric, as a behavioral health hospital, we won't take a person into inpatient that doesn't have a heartbeat of 40 or more and an IBW of 60%, which is really pretty low. Somebody who can't meet those requirements really needs, is close to intensive care at any minute, and is just really too dangerous for us. But some programs, particularly programs that live inside acute general hospitals, can take them. There aren't that many of those, but they could take them. And so that's your medical stability. We also use hospital for folks that have poor behavioral control. If we need to really control the environment to that extent, then that's where we'll use the hospital. But you can go down and read through the various, at your leisure. You can go through this. Now, you shouldn't take this as meaning that this is what, when you call an insurance company, that they're going to be looking. They're certainly not looking at the Walden grid. They're looking at their own grid, and it's funny. If you're having trouble with getting somebody in or getting level of care determination, ask them to send you the guidelines. So they might, if they're published, they'll tell you it's public, but they won't make it too easy for you to get it, I assure you. If you look at the right-hand side, that's kind of where we're at now, pretty close. So I was looking at it, and the one thing that's not on there that I think has, gotten to be close to a level of care, and is actually a pretty cool thing for some people, is a transitional living. So it's not on my list, but hopefully it will be soon. So inpatient, residential, partial hospital, intensive outpatient, and blame the fashion industry and social media. Looking into the future a little bit, and kind of moving into thoughts about this population in particular, we're going to need all of the above. We certainly need more prevention. Family-based treatment, I think, is absolutely essential. In the introduction, you heard I'm a family guy. Probably the one good thing, I wouldn't call it good, but it is good in this way, that of the age of onset getting younger is the possibility of greater parental and greater family work, which means greater parental control earlier on. And actually, I think prognosis really is much better in some ways by catching it very young before it becomes more of a hardened behavioral pattern to go along with whatever else is there. And one of the great things about family therapy is sometimes you can make a intervention and a change with the parents, and that'll change it very quickly for the kid. So you have more pieces to work with. You might be able to make small changes in a number of places and it have a huge effect. We have to be looking at the school's role. We have to be really connecting treatment to home and community. I think the next one is really critical. I'm going to talk a little bit about technology, but being able to extend treatment and to have treatment or treatment-like services available when young adults want to take advantage of it is going to be critical, because that's how they think about these things. And finally, maybe we'll get to some medicines that work for our disorders. There are very few, but hopefully downstream we'll get something that works. Talk a little bit about what I think might be the disconnect that I talked about at the beginning is, what we believe is that in the process, treatment takes time, recovery takes time. And we think that it's all about working the process. And teens and young adults don't necessarily believe, I'll show you some data in a minute, that they have a problem. Anorexia in particular is one of the most confounding conditions ever. It's one of the few medical conditions where the patient doesn't want to get better often. I mean, that's amazing. Life is about right now. Is there a pill or an app to fix this? Well, the pill goes with the previous generation. We have lots of that right now. We have you want a bariatric surgery or you want a pill to fix whatever it is. Well, kids, young adults, They're looking for a technology. They want the app. They want to be able to call it up on their phone. So work hard, play hard, and recover hard means, can we do this quickly and get it out of the way? So that's what they're thinking of. Kim talked a little bit about this. The high expectations for a lot of the people, the kids, particularly in college, who are who we're talking about. We started going into some of the research around this, and teens are more likely than adults to report that their stress level has slightly or no impact on their body or physical health. Anybody with kids relate to that? Yeah, they're just disconnected. You know, it's half the time it's, oh yeah, don't bother me. Teens report experiencing both emotional and physical symptoms of stress in similar proportions to adults. So they report having the feeling of stress, but not being able to connect it to the body. Although teens do not appear to recognize the potential impact on their physical and mental health, they often struggle to cope. Only 50% report feeling confident about their ability to handle their personal problems. 50%. That leaves 50%. Half of the world, of the young world, doesn't believe it can cope. When kids think about inpatient, this is prison. When they think about residential, sometimes we get this as a vacation from my overbearing family. They actually see it as a break. Partial hospital, if I greet everything, I can be discharged sooner. Intensive outpatient, I can't wait to have my nights to myself again. An outpatient, I wonder how long I can keep up the appearance that I am better. So, you know, a lot of times, we experience this. You know, stepping patients through levels of care. There seems to be compliance. There seems to be, they're showing up at appointments. But recidivism is still pretty high. Doesn't take long sometimes. You know, are they really getting it? And do we really know? This is stuff that you've already seen probably. Kids are not all right. This is essentially, the general population numbers. Lots of kids. In 2010, 22 million high school-aged adolescents. Of that group, about 400,000 are female, and I'm not sure how they got this number. 170,000 are males. Grand total of somewhere around 600,000 of adolescents requiring treatment, and somewhere around certainly less than a quarter are getting the treatment they need. We decided to take a little bit more of a look into what's available at this point from around social media and the impact of social media, the elephant in the room. 1 in 4 kids say it is a lot or somewhat like them, that they often feel rejected by kids their age. 26% often feel sad or depressed or lonely. 35% say they worry about people tagging them in unattractive photos. 27% say they get stressed out about how they look when they post pictures. And 22% say they feel bad about themselves if nobody comments on or likes the photos they post. And 52% of the less happy group say they sometimes wish they could go back to a time when there was no Facebook. I had a similar situation with my daughter a few years ago, and she went off to summer camp, and after 2 weeks, 3 weeks, whatever, we picked her up, and she just looked so much better. She was relaxed. And we said, well, it looks like you had a good time. And she said, I didn't worry about anything. We had no phones. We had the campfire. So there's something to be said about the old way in relation to this. And that genie's not going back in the bottle. So I'm not making that point, but we do have to deal with this. We do have to deal with this. And we have to work with parents around this. They don't know this yet. 10 to 20% of college-age women, 4 to 10% of college-age men meet the criteria for eating disorders. About 35% will be treated at a specialized facility. So, takeaways. Too many adolescents and young adults do not have strategies to cope. Eating disorders are a go-to coping mechanism at this point. High percentage struggle and do not receive adequate or any treatment at all. And here's kind of one of the things I'm really concerned about. You know, we encourage, a big part of what we do in all of our programs and in outpatient practice, whatever, is to gain trust with our patients and to encourage them to speak with us, which is hard enough as it is. But, you know, it is pretty much the predominant practice on college campus that if you come forward with an eating disorder, you go home. It's not going to be long before you're asked to take a leave of absence. And if you do it a couple of times, you're probably going to be out. So we have to, this is really concerning to me. And it's something that we need to think about and help our colleges think about. So, very quickly, what factors do we need to consider in developing an effective system of care for this age group? What does the village look like? Actually, here's the village, right? How many, you don't have to say if this is your child. How many people in the room know a adolescent or child who sleeps with their phone? Come on, thank you. All the time, they sleep in with it. That's the village. It's with them all the time. They're getting messages all the time, and it's global. And unfortunately, you know, you can find anybody in the world, and if you're a depressed adolescent who is kind of sliding off, generally you look for people who you think can understand you. And that's who they're seeking out. That's who they're talking to. And after a while, that's all that they're talking to. It seems like that's the whole world. The treatment gap. So here's where I think we're at. And this is something that I think as professionals, we have to work on this. We need more research. You know, we have, if you look at the top, we have evidence-based treatment for children and younger adolescents. FBT is really, you know, the state of the art. It works really well. It doesn't work for everybody. That's, you know, but it works quite well. But it starts to work less well as you get a little older. We really think about it as, you know, you could, you know, 15, a young 16, you know, a youngish, even a younger 17. But at some point, it starts to be less effective. You got evidence-based treatment for adults, CBT. We have good belief in CBT and DBT. What do we have for the group in the middle? Well, we use all these things. We use all these things, but it's not clear to me that they're as effective for this group as they need to be. So, you know, I just point that out. That seems to be a gap for this group. Just some things to think about. A couple years ago at Walden, we incorporated a nonprofit to work with us and to do a variety of things. And the main thing that it does right now is that it provides a awareness and prevention program in middle and high schools. I think this is really important because we need whatever we can find as an antidote to all those messages and to the larger society that we're immersing our kids in. We have to start to actively teach and give messages earlier and earlier because they're getting the other stuff very strongly. Family-based treatment, and not just family-based, meaning working with the family, but family-based meaning in the home. That will be the next thing that Walden Behavioral Care does, is to go into homes and work with families in their homes. Working with the schools, technology has got to be, and probably be the biggest part of that. And yeah, I think we have to consider who these people are and when they actually will really listen and participate. Early morning is not going to work. You know, I don't know about you, but my observation and recollection is that it's mostly at night that teens and young adults are willing to have a talk and, you know, kind of delve into these things. You know, I'm not up. I don't know if you're up, but we're certainly not in the office. So college, again, prevention. You know, this one of the things about, I don't know if this is on another slide, but you know, in some colleges, maybe more, that are really starting to get into the issue of eating disorders at orientation, and really starting to talk about that in a good way. And so that's the same idea as providing an awareness curriculum. The problem is that when you know, it's that first week of college, and it's almost always done at orientation, and it's a huge amount of stuff that's being provided to a kid who's away from home for the first time, and it's not clear what they're listening to. You know, and particularly if they haven't had any issues with eating, then it's probably not something that they're paying that much attention to when they're hearing that. So it would be great to have it a little bit later or a little bit more continuous. And working with peers, I think, again, working with the whole role of the college as in loco parentis, which is obviously the college becomes the parent. But our colleges are pretty scared about eating disorders and don't have high tolerance for this. We need to work around that. And probably more than anything else is the technology issue. We know how much technology is working against us. We have to figure out how technology can work for us. You know, social media has totally changed how children, teens and adults receive and digest information. For some social media sites, I said this already, it's the gasoline to the fire. How do we deal with it? Well, we have to figure this out. We're going to need our adolescents to tell us, but we have to make it cool somehow. I mean, how many college students are going to sit down and work through, you know, and read, you know, Fairbairn's book? You know, they're not. They're just not going to do it. How many would read an HTML version with graphics? You know, maybe there's a way to take things that we already have and just repackage them in a way that's more digestible. And we haven't thought about that yet, but I think we really need to do something like that. We are seeing the growth of recovery-focused apps. Walden is working with Recovery Record. Rise Up is another one. There's a couple more that are coming. This is good stuff. The biggest problem with the apps is populating is person using it and populating it, but at least it's right there. At least it's at the moment that things are happening. You can send messages. You can send reminders about skills. There's lots of stuff that can be done with it. I think of it not so much as an answer that we have right now, and more as a vehicle. It's a delivery system. We have to do a lot more with it, but at least we know that we could communicate with people of this age constantly. Starting the conversation in high schools, in middle schools, in colleges about these issues. That's another one of the things that our the Walden Center is doing, is just getting the word out. We'll have some spots. Allie Raisman, Olympic gymnast Allie Raisman, is our media spokesperson. She's a great kid and a very good model of kind of healthy attitudes towards body and health and eating, and her message is going to be just let's talk about it, let's get it out there. So I think that's the message. Teens and young adults deserve care that meets them on their level. We have work to do. With more targeted approaches, better outcomes might be experienced. Let's talk about it. Thank you.